Hello students, welcome to chapter 22, Surgery and Nutritional Support, part 3. So we're reviewing the previous sections, all related to enteral feedings, parental feedings, the criteria to select what type of feeding, what type of formula, where the tube is going to be placed, and all these criteria that help us support the recovery of the patient. So in this part, we are going to talk about special nutrition needs after gastrointestinal surgery. Just remember that this chapter is fundamental. It's critical for you if you want to work in a hospital. You need to master this chapter, okay? So mouth, throat, and neck surgery. So these patients that are having this type of surgery, remember that the gastrointestinal starts in the mouth and ends in the anus, okay? So we are dividing this section depending on the problem, the surgery the patient has. So if the patient has a surgery in the mouth, throat, and neck surgery, right? The modification regarding the mode of eating is important. Clients who cannot chew or swallow normally are included in this part. So they cannot chew. Okay, now we are having problems with amylase that is coming, is an enzyme from the pancreas that is being released when we chew, right? So remember, the pancreas has 3 enzymes: lipase, that is the one in charge of metabolizing lipids; protease, the one that is in charge of metabolizing the proteins; and amylase for carbohydrates. But the only one that is present in the mouth is amylase. So right now, if the patient cannot chew, there is a problem with amylase. On top of that, if the patient cannot swallow, now we are having issues with the saliva. Okay, so because we need that food to have some hydration in order to pass through the esophagus and get into the stomach. So the ultimate goals are to promote healing, prevent nutrient deficiencies, and minimize complications such as malabsorption. Okay, this will be in reference to amylase, maldigestion, right? Because you are not going to be able to digest and to absorb if you don't have that particular enzyme in your stomach when the bolus gets there. And dysphagia. Dysphagia is difficulty swallowing, okay? So that's good to know. That's why they require tooth feeding. Oral liquid feedings are given to patients, to clients who can drink and swallow without complications. So it's oral, right? Clients who have had an esophagectomy and are at risk for dumping syndrome may have difficulty tolerating liquid feedings, okay? Because at the end, all the food is going through the esophagus, okay? So what is dumping syndrome? I want to share with you this video so you can understand much better. And I usually select videos from Alila Medical Media. They are very good videos. So let's watch this one. It's at 2-3 minutes, no more.
Dumping syndrome is a very common complication following gastric and esophageal surgeries. Also known as rapid gastric emptying, dumping syndrome is a condition in which undigested food moves too quickly from the stomach to the small intestine. In other words, food gets dumped into the intestine before being properly digested. This happens because the valve that separates the stomach and the small intestine, called the pyloric sphincter, was either removed or damaged in the surgery. There are 2 forms of the disease, based on when symptoms occur, early or late. Early dumping happens between 10 to 30 minutes after a meal. Symptoms arise as the rapid dumping of the undigested, concentrated food mass triggers the body to move fluid from the bloodstream into the intestine in an attempt to dilute the food. The resulting distended intestine produces bloated feelings, abdominal cramps, nausea, vomiting, and diarrhea. This shift of fluid, when excessive, may also significantly reduce blood volume, causing rapid heart rates, dizziness, lightheadedness, or even fainting. Late dumping symptoms occur within 1 to 3 hours after eating. At this point, the rapid increase in sugar absorption triggers the pancreas to produce more insulin in an attempt to prevent too high levels of blood glucose. However, it may overreact and produce too much insulin, causing instead too low blood glucose levels or hypoglycemia, which may manifest as weakness, sweating, confusion, and tremors. Increase in gastrointestinal hormones is also observed and thought to contribute to both early and late symptoms. Symptoms are often more severe after meals that are high in simple carbohydrates, such as table sugar. Most cases of dumping syndrome can be successfully managed with diet changes. These include eating smaller meals throughout the day, avoiding foods with high simple sugar content, choosing foods that are rich in proteins, fibers, and complex carbohydrates, delaying liquid intake until at least 30 minutes after a meal, adding thickening agents to increase food consistency. If these fail, medications that slow down gastric emptying or inhibit insulin release may be prescribed. Tube feeding that bypasses the upper digestive tract or corrective surgery such as reconstruction of the pyloric sphincter may be performed as a last resort.
Thank you so much. That was an excellent video. So in a few minutes, you get to know the knowledge of dumping syndrome, okay? So we are talking about mechanical soft diet, right? So before oral liquid feedings, okay, for those patients, again, who had esophagectomy, means any surgery or removal of the esophagus, are at risk for dumping syndrome and may have difficulty tolerating liquid feedings. Now, mechanical soft diet. These diets help to transition between full liquid and regular diets. These diets may include whole foods that are easy to chew and swallow, and you can go back to table 22.4 in which we saw the clear liquid diets, full liquids, and the mechanical soft diet. Now, mechanical soft diets do not include high fiber food. High fiber food are your raw vegetables, your raw fruits, right? It may be prudent to provide a functional fiber supplement. So some patients are going to have Metamucil, which I really believe is better to get the natural source of fiber, such as psyllium husk, okay, but with certain instructions from your nutritionist, because not everybody can have full amounts of fiber, right? They need to tell you exactly how much, right? Until your GI is fully working, okay? Multivitamins and minerals supplemented in liquid form help to ensure micronutrients intake during the initial recovery period. Yes, because if your GI is not fully functional, now we're going to have malabsorption, digestion, so we need multivitamins and minerals. Enteral feedings. Severely debilitated patients who have had radical neck or facial surgery may benefit from tube feedings. Okay, remember, we are still in the section of the patients that are having issues or they had a surgery in the mouth, throat, and neck surgery, right? So we are discussing the type of feeding. So these type of patients that are receiving enteral feeding, okay, they could be at home, and nasogastric tubes are the tube of choice unless an obstruction of the esophagus or other complication requires the surgeon to create a gastrostomy to access the stomach. Let's remember that the nasogastric are tubes that are going to enter through the nose, are going to go down through the esophagus and entering the gastrointestinal area. So if the patient is having any issues in that pathway, now the surgeon is going to create a gastrostomy, which is a stoma, a special opening that is going to bypass all that pathway and is going to go directly into the stomach or maybe the small intestine, okay? If the esophagus and stomach are working properly, then the best practice is to use them, is to use those organs, okay? Now let's talk about gastric surgery. I know everybody is waiting for this and the bariatric surgery. Let's start with the gastric. Nutrition problems. Gastric surgery poses a special problems for the maintenance of adequate nutrition. Yes, because in the stomach, we are releasing a lot of acids. We have the parietal cells that are in charge somehow in the metabolism and production of vitamin B12, right? Also, if you have a lot of bleeding in the gastrointestinal or you're losing blood because you don't have enough hydrochloric acid, as we explained on the first chapter, you're going to have iron deficiency anemia. So basically, gastric surgery poses special problems for the maintenance of adequate nutrition, right? Even if you are eating your enough protein, carbs, and fats, if you are having any issue in the stomach, you are not going to have a good absorption, right? These problems may develop immediately after surgery, depending on the type of surgical procedure and the individual response. So think about those patients with gastric cancer. They have a complete gastrectomy. They are removing the stomach. How are they going to survive? Problems that are having partial gastrectomy, depending on the area in which they had the surgery, what part of the stomach was removed, right? So other physical or malabsorption complications may occur later when the person begins to eat a regular diet. The goals of nutrition therapy are to promote healing, to prevent dumping syndrome again, right? Which is the rapid passage of the food straight into the intestine, and nutrient deficiency, and to minimize complications such as malabsorption and mild digestion. Okay, so the healthcare team may consider using multivitamin mineral supplements in liquid form, vitamin B12 injections, or functional fiber supplements. So we know this. Gastrectomy. Okay, so gastrectomy is the complete removal or partial removal of the stomach. Increased gastric fullness and distension may result if the gastric resection also involves a vagotomy. What is vagotomy? Is the removal of the vagus nerve. That is the one that is motivating the stomach to move. Okay, the vagus nerve. So because it lacks the normal severe stimulus, the normal nerve stimulus from the vagus nerves, the stomach becomes atonic, meaning no tone, and empties poorly. Okay, so food is going to stay there instead of moving around and um, moving to the next level, which is the small intestine, right? Food fermentation occurs because it's going to stay there, and this produces discomfort, gas, and diarrhea. Weight loss is common after extensive gastric surgery. To cover the immediate post-operative nutrition needs after the gastrectomy, surgeons may create a jejunostomy through which the patient can ingest an enteral formula. So the stomach was removed. We cannot insert a nasogastric tube because we know the pathway is going to be through the nose, the esophagus, and the stomach, but the stomach is removed. So now the surgeon is going to create a jejunostomy, which is an ostomy, an opening straight in the jejunum. And then let's remember, as I explained before, the small intestine has 3 parts. An easy way to remember is to remember the acronym DJI. When D stands for duodenum, J is the jejunum, and EI is the ileum. So when the surgeon is creating a jejunostomy, is even bypassing the first part of the small intestine, which is the duodenum, okay? And actually, the jejunum is the biggest part of the small intestine, okay? And that's good to know. The jejunostomy is going to be a practice, a ostomy, that is created after gastrectomy. NCLEX alert. You're going to see this in your NCLEX and probably in my exam. The basic principles of diet therapy for the immediate post-gastrectomy period involves both the size of the meals, which should be small and frequent, and the nature of the meals, which are generally simple, easy digested, bland, and low in bulk. So you don't want high fiber food. They have to be very low in bulk, right? And probably it's going to be first like fluid liquid or a small puree diet. Okay, so I have included here a website from Mayo Clinic that you can access to see, right, the low residue diet foods, okay, after gastrectomy. Here, let's put this here. Oh, it's the National Cancer Institute, okay, which is even better because they have, they have every single type of patients that are having different types of gastric surgery. So you have the whole page is talking about different practices, okay, even diets. So here it is, National Cancer Institute. Look for diet and nutrition after gastrectomy, your plan, okay. So it's available. I'm going to include it in the supplemental material when I give you the link for this video. So dumping syndrome, okay. Complication subsequent to extensive gastric resection. We know that when the person begins to feel better and eat a regular diet, he or she may experience discomfort 10 to 20 minutes after meal. Okay, with early onset dumping syndrome, a cramping and full feeling develops. The pulse rate becomes rapid and a wave of weakness, cold sweating, and dizziness may follow. Be careful with this dizziness. You don't want a patient post-surgery to fall. Okay, be careful. Orthostatic hypotension, because the blood pressure is going to change. Abdominal pain and diarrhea terminate the event. For individuals with intermediate dumping syndrome, symptoms began within 20 to 30 minutes after eating. So the first one is the early onset, 10 to 20 minutes. Then you have the intermediate, which is going to be about a half an hour after eating. And for those experiencing late onset, this is going to be 1 to 3 hours after a meal. So the period in which you need to monitor a patient after this type of surgeries is just 10 minutes after eating all the way to 3 hours. And in fact, you have to monitor the patient the whole day, because remember, these patients needs to have a small and frequent meals so they can develop. For theory, this is good. Every 10 to 20, every 20 to 30, every 1 to 3 hours. In the theory, it sounds good. But in the practice, when the patient is eating small meals very frequent, you lose track of how often it is. So you have to monitor them all day. A meal containing a sizable portion of readily absorbable carbohydrates rapidly enter or dump into the small intestine. Here we are entering into the war zone, because we need to master what type of food the patient is taking. Okay, if it's high fat, high protein, high carbs. But let's review again this. A meal containing a sizable portion of readily absorbable carbohydrates, carbs, rapidly enter or dump into the small intestine. So is the carb, right? A stomach bypass allows food to pass quickly from the esophagus into the small intestine. So the carbs are passing from the esophagus to the intestine. This concentrated food mass draws water from the circulatory system, hello, important, from the circulatory system into the GI tract to achieve osmotic balance, which is a state of equal concentration of fluids within the small intestine and the surrounding blood circulation. So, in other words, so you have the food is in the small intestine. We need water in order to dissolve the food, the bolus, and then to absorb all the nutrients. However, when the dumping syndrome is there, the carbs are going to remove the water from the circulatory. And remember, I told you, not only the gastrointestinal is full of nerves, but the amount of circulation, vessels, and arteries is huge, because think about it. Every time you eat, all the nutrients get into your body through the circulatory system, okay? So if you are eating, all those nutrients needs to get to your body through the veins and arteries. So the gastrointestinal is full of veins and arteries. So now these carbs are entering and are absorbing, removing the fluids from the circulatory system, and is entering into the small intestine, creating an imbalance, right? This concentrated food mass draws water from the circulatory system into the GI tract to achieve osmotic balance. This water shift rapidly shrinks the vascular fluid volume, thereby causing shock. So if you remove the water from the circulatory, you are going to have hypovolemic shock. Remember, we review first the euvolemic, which is the normal state in the circulation. Hypovolemic means that there's less fluid in the circulatory. So this patient with the dumping syndrome is causing hypovolemic shock. Blood pressure drops, of course, and signs of rapid heart rate to reveal the blood volume appear. So now the poor heart starts to pump very fast, right, to compensate that hypovolemic shock, and it's never gonna happen because there is not enough fluid. Okay, so these include a rapid pulse rate, sweating, weakness, and tremors. And if somebody is having weakness, okay, and a low blood pressure, which is hypotension, a patient can fall, okay, easily. You can have a patient post-surgery with a hip fracture or a knee, in needs of a knee surgery, okay, so you need to monitor. And that's good to know. Water shifts from circulatory to intestine, causing decreasing in blood volume. That's good to know, okay? If a client eats a meal consisting of simple carbs, late dumping may occur approximately 2 hours after eating, okay? So, Dr. Matalana, what is simple carbs? What is complex carbs? Here I'm coming to the rescue. Let me play a video so you can understand. It's a basic video, okay? Nothing too complicated.
What's the difference between a simple carb and a complex carb? Carbohydrates are your body's primary source of energy, but not all carbs affect the body in the same way. And when trying to lose weight, the first step people often advise is to cut them out completely or to only eat complex carbs. Why? And is it okay to not eat carbs at all? First of all, a zero-carb diet is virtually impossible. Even leafy greens and animal protein contain carbs. And we need some carbs to survive, but if you are watching your health and weight, you should choose them wisely. Soda, packaged cookies, most breakfast bars and cereal, baked goods, and even many gluten-free products are known as simple, refined, or empty carbs. These highly processed foods are full of sugar and low in other nutrients. The problem is that these kind of carbs are digested rapidly, In the short term, they can seriously rev up your energy levels and blood sugar. But before you know it, you're likely to feel hungry again, or your energy levels will come crashing down. And in the long run, eating a lot of refined carbs can cause massive weight gain and more health problems. On the other hand, complex carbs are made up of 3 components: sugar, fiber, and starch. So it takes your body more time to process them, keeping you feeling full for longer. But that's not all. The fiber in complex carb-rich foods helps your digestion run smoothly by flushing out toxins and waste more easily. So, my number one piece of advice for people trying to slim down is to know which foods can help lift you up and which ones can drag you down.
Thank you, doctor. So I selected this video because I've seen many of you in the classroom with your coffee, milk, and some sugar, and eating your chocolate chip cookies during the class. Also, I've seen some of you getting your sodas and Doritos, right? So those are simple carbs. So yes, 5 to 10 minutes after eating that, yes, you are going to feel great. But then after 15 or 20, your sugar, your energy is going to drop. Okay, and you are going to feel that you want to eat more, and since you are not having energy, you start sleeping, like it's occurring every single class. Instead, if you get to the class with a bottle of water and maybe one apple, it's going to be a complex carb, right? So you're going to feel full, but your energy is going to stay stable at least for the entire class, because complex carbs are they metabolize slowly. Okay, so what am I saying? Before the exam, you have to select complex carbs like salads or raw vegetables, raw fruit, and good amount of water, okay, to keep the energy. Do not sleep in the exam, or do not feel tired, okay, instead of getting your peanut bread and peanut butter with jelly, okay, maybe your coffee and milk and some sugar before the exam. That's a no-no. Or a bagel, okay, or a muffin, cookies, that's a no-no. Okay, so let's go back to the concept. So if a client eats a meal consisted of simple carbohydrates, late dumpling may occur approximately 2 hours after eating. We were there. The quick absorption of a concentrated simple carbs solution results in a rapid rise of blood glucose and an overproduction of insulin. Blood sugar level eventually drops below normal, causing symptoms of hypoglycemia, weakness, shaky, sweating, confusion. As a result, susceptible individuals are often reluctant to eat much food, and this may lead to unintentional weight loss and general malnutrition. So because they were selecting the wrong food, then at the end, since they saw the consequences and the symptoms, they prefer do not eat, and that is going to cause weight loss and general malnutrition, right? Okay, so then clients may find that choosing carbs with a low glycemic index, and this is good to know, NCLEX alert. So clients may find that choosing carbs with a low glycemic index, okay, like your fruits, your vegetables, eating slowly, you chew many times, eliminating fluids during meals. So you are not only reducing the fluid when you are eating, which is important as well, because you want to prevent that passing. That is basically the definition of dumping syndrome, the easy passing of food, right, to the small intestine. So if you reduce the fluids, you're going to reduce that syndrome. And reducing dietary fat and lying down for 15 to 30 minutes after eating will help to decrease the rate of gastric emptying. Let me review this again. Clients may find that choosing carbohydrates with a low glycemic index, so food that are low in glucose, also eating slowly, reducing the fluids, reducing the fat, and lying down for 15 to 30 minutes after eating, because gravity, if you are sitting, the dumping is going to be faster. But if you lay down, you are going against gravity, right? Make sense? Okay, so it's going to help decrease the rate of gastric empty, okay? And that's good to know. NCLEX alert. So for example, let's pick up an example. What type of food should I avoid if I want to avoid dumping syndrome? So I'm going to choose something that is low glycemic, right? What about if I eat chocolate pudding, for example? Chocolate pudding is high in sugar, which is contraindicated in this case, and it's high in fats. So right there, this can cause dumping syndrome, even though it's a soft food, but because of the content on the food itself is going to cause dumping syndrome. Bariatric surgery, yes, I know you were waiting for this. Bariatric surgery are often malnourished before the surgery. The patients are going to be malnourished before the surgery. That's why they are doing the surgery, because they are overweight, they are obese, they have morbid obesity, right? So they are malnourished. Their nutrients are the wrong nutrients. And before the surgery, they are in this state. So this can exacerbate complications. So these individuals are at risk for several micronutrients. Let's review again. Micronutrients are your vitamins and your minerals, versus macronutrients are your proteins, your carbs, and your fats, right? And these patients require special consideration. After gastric bypass, clients progress slowly from a clear liquid diet to a regular balanced solid diet over a period of approximately 2 months. In theory, this is good, but there are many factors we need to consider, but this is the average, okay? So after bariatric surgery, the combination of severely reduced food intake and potential malabsorption or dumping syndrome dramatically decreases nutrient availability. So now you have to consider if the patient is compliant. Okay, psychology plays a huge role here. Somebody who has a morbid obesity and is used to eat 4 breads in the morning with 6 sausages, right, and 2 eggs, suddenly find itself that he needs to eat half bread, right, with only some scrambled eggs. So that's the psychology is important. It's not going to be easy for that person to adhere, to be compliant. And also you need to consider if the team, the patient is having, how good they are. Are they often taking care of patients with morbid obesity, or they are just most of the time taking care of patients with obesity levels? Okay, so we are talking morbid, 30, 35 BMI and above. Okay, so it takes also the support of a good team, nutritionist, the doctor, the psychology, to help these patients that are going through bariatric surgery. And also the financial situation of the patient, the level of education. So in theory, 2 months is good, but you have to consider all these different factors. So after bariatric surgery, the combination of severely reduced food intake and potential malabsorption or dumping syndrome dramatically decreases nutrients availability. Gallbladder surgery. So gallbladder, these patients are going to have gallbladder inflammation, which is cholecystitis, or gallstones, which is cholelithiasis, okay? Basically, these gallbladder stones are produced for excessive fat consumption. But Dr. Matayana, I don't eat fats. Okay, now let me assess even further. What type of proteins are you getting? Well, I eat pork, I eat my sausages, and I have red meat. So right there you have a lot of animal fat that is not bad, but if you get this in excess, it's going probably you can have these gallstones. Now, if you eat that and on top of that, you add a lot of butter to your bread, and then you have your yogurt, full whole milk yogurt, right? And you are cooking with canola oil, you name it. Okay, so cholecystectomy is the removal of the gallbladder. The modern procedure for this removal is laparoscopic cholecystectomy. They are going to make small holes around your gallbladder, and the same day you're going home. After surgery, reducing fat in the diet, less than 30% of total energy intake as fat, facilitates wound healing and comfort. The hormonal stimulus for bile continues to function, thus causing pain with the high intake of fatty foods. So right now they remove the gallbladder, which is the one that secretes bile, which is the one that helps you with the fat metabolism. And now you try to go back to your regular diet, and now you have horrible pain because you don't have the support of the gallbladder, neither the bile. So you need to work in your psychology also. You need to work on your lifestyle changes, your habits. Okay, so NCLEX alert to reduce fat after cholecystectomy. That's mandatory. You need to change your lifestyle. And then you have to eat low-fat diet for gallbladder disease. If you are having cholecystitis and the doctor told you, just reduce the fat because in this moment you don't need the surgery, so you need to cut in fat. Okay, now you have a nice case study here for you to practice. And then let's talk about nutrients deficiency after bariatric surgery. So this surgery is effective for weight loss and maintenance, but it's not without drawbacks. Okay, so it has a lot of risk. Restrictive eating patterns, dumping syndrome, and nutrient deficiencies from malabsorption are common complications. So you have to be ready for dumping syndrome if you're getting bariatric surgery. Okay, you have to be ready to change completely your nutritional habits. And since you're having the bariatric surgery, you have to be ready for malabsorption and common complications. So there is a nice video about the, and I really select this video for you, class. I've been very worried since lately I've seen too many adolescents, young adults, age 17 to 19 years old that are having obesity, morbid obesity, sorry, and they are selecting to go for the bariatric surgery. The most common procedure is called the ROX and Y gastric. And I want to show you what is it about. They get very enthusiastic. Oh, I'm going to lose weight. I'm going to be able to get into jean size 4 or 2 versus right now I'm size, I don't know, 20, 24, whatever. So they see only the benefit, the physical benefit, but they don't see the healthy risk. So let me play this video so you can have an idea what is really the bariatric surgery. Okay.
In Roux-en-Y gastric bypass, the surgeon creates a small pouch at the top of the stomach. The pouch is the only part of the stomach that receives food. This greatly limits the amount that you can comfortably eat and drink at one time. The small intestine is then cut a short distance below the main stomach and connected to the new pouch. Food flows directly from the pouch into this part of the intestine. The main part of the stomach, however, continues to make digestive juices. The portion of the intestine still attached to the main stomach is reattached farther down. This allows the digestive juices to flow to the small intestine. Because food now bypasses a portion of the small intestine, fewer nutrients and calories are absorbed.
Okay, I'm gonna stop the video here because I want you to realize something. So now we have the top part of the stomach, only the part that is connected to the esophagus. And that part, which is a little pouch, is gonna be connected to the jejunum, okay? Now, we are skipping the nutrients and the activity of the stomach because the big part of the stomach is disconnected from that little pouch. So now we are having problems with B12, the parietal cells. We are having problems with hydrochloric acid that is secreted by the biggest part of the stomach that is going to cause iron deficiency anemia. Plus, when this big part of the stomach is connected directly to the part of the jejunum that was anastomosed, right? This part is not passing through the bile and gallbladder to get the help of the bile to metabolize the fats, the fat contents. So let me say it in another word. So you have patient is eating, going through the esophagus, now goes to the small part of the stomach. That food is going straight to the jejunum and is not passing through the bile and gallbladder for fats. No, also is not passing through the stomach for hydrochloric acid and B12. Okay, now this hydrochloric and B12 is entering the jejunum at a later stage. So we are changing the order of the metabolism. Okay, that's what is happening when you get the Roux-en-Y gastric bypass procedure. Bariatric surgeries that induce malabsorption, and this is happening very commonly right now because we have a lot of obese patients in America, especially young adults. So instead of promoting to make exercise and to eat the right food, we are promoting our kids to go through this surgery at a very young age. So bariatric surgeries that induce malabsorption present nutritional problems. Protein deficiency is a significant risk for many patients and may result in hospitalization and the necessity of nutrition support in severe cases. In addition, micronutrient deficiencies from limited intake and malabsorption warrant multivitamin mineral supplementation post-op for life. Is for life. You need B12 for life. You need to check iron or maybe iron transfusion for life. Okay. Some of the vitamins that we need to monitor post surgery are going to be vitamin A, your B's, your vitamin B's that are essential for neurological system, right? Your vitamin C, which is essential for healing and also for the immune system. Your vitamin D, E, and K. So are your fat soluble vitamins. Again, A, D, E, K. My acronym is ADEC. I remember that, fat soluble. Also your B vitamins, including folate. Folate is also type of B vitamin. And in minerals, you have to worry about your calcium, right? So in the long term, the patient can have osteoporosis, copper, iron, selenium, and zinc. Okay, so here they are talking about how much of the vitamins and minerals are going to be recommended based on the patient state. I'm going to skip that because it's very individual, and these numbers are good for the theory, but in reality you need to keep drawing blood every month or every 3 months to get into the habit of knowing how much each patient is going to need. And also you need to consider what are they eating. So if they are not getting the vitamins through the nutritional support, now you have to decide how much they need in terms of supplement, right? Now let's move to intestinal surgery. Intestinal disease that involves tumors, lesions, or obstructions may require the surgical resection of the affected intestinal area. So in terms of intestinal, now I'm talking about patients that are having intestinal obstruction, maybe because they got constipation and they are not able to poop. Now we are having patients with Crohn's disease, patients with ulcerative colitis, patients with cancer in the small intestine or in the colon, okay, patients with diverticulitis, okay. I'm just throwing some names, but all are related to intestinal. So for complicated cases that require the removal of large section of the small intestine, the use of EN support may be difficult at first. Remember that enteral is going to go straight to the intestine, but if they are having resection, now we have an issue there. In this case, the medical team may use PN support, parental nutrition through the veins, either peripheral or central, right? With a small allowance for oral feeding, because it's the same. If you get food through the oral, at the end, it's going to go through the esophagus, the stomach, and the intestines. But this patient is having removal of the intestines, so they cannot get oral feeding. After general resection, for less severe cases, a diet that is relatively low in dietary fiber may be beneficial in the beginning to allow for healing and comfort. Okay, so here we have a very nice graphic. This is cholecystitis, right? Cholelithiasis, because we have gallstones. Lithiasis means stones. Chole is related to the gallbladder. So we have the gallbladder with the stones inside of the gallbladder. And here you can observe that some stones are moving to the common bile duct. Okay, now this common bile duct is a duct that is unifying the pancreas, the liver, and the gallbladder. So if we have a stone in that area, now we have a huge problem, because all the enzymes coming from the pancreas or the liver are going to return. They cannot pass freely to the duodenum. Okay? And it's so easy to eat the right food, less fat, to avoid all these complications. Okay? So now, the GI tract sometimes require creating a stoma. We saw that if the patient is having a small intestine surgery, we need a stoma, opening the abdominal wall to the intestine for the elimination of fecal waste. And it's going to be ileostomy when the stoma is going to be on the ileum. Remember your DJI. Now the jejunostomy is not possible. We need to open a ileostomy, which is the last part of the small intestine, very close to the colon. Okay, so at this point in the GI tract, the stool is still liquid, which may cause problems in managing the ileostomy output. Okay, let's put some things in order. So we are going, do you remember I told you about the amount of fluid that the small intestine needs to make the food more hydrated and to make the nutrients more absorbable, right? So when the food passes to the colon, so we have the food in the duodenum, then goes to the jejunum, that goes to the ileostomy, right? The ileum, right? And then from there is going to start the pathway to the colon, ascending colon, transverse colon, and descending colon. So when the food enters the colon, the large colon is the lazy in the system. The only job the large colon does is absorb water. So all the water the small intestine release, the colon is going to absorb it, right? So you can have a nice bowel movement, and you are going to make poo-poo only a content that is out of water, okay? The colon is going to absorb water if it reads water in the system. If you don't drink enough water, the colon is not even moving. That's why people get constipation. That's why we need to drink water, eat fiber, and walk. Okay? So now, when we have ostomy in the ascending colon, that part is having a lot of water because it's coming from the ileum. Okay, so if we have a ostomy there, that poo-poof is going to be having more water. If the ostomy is on the transverse colon, now the stool is going to be more like paste-like with less water content. Now we have an ostomy in the descending colon, we are going to observe less water because it's heading the exit of the system. Okay, so you as a nurse, you need to observe. If I see a patient that is having a ostomy in the descending colon, ready to the exit, but is very liquid, something is wrong. That means that that colon is not working, it's not absorbing water from the ascending to the transversal. There is a neurological issue and you need to report that. Okay, patient is having diarrhea. Okay, so now clients need support and practical help with learning. And that's good to know. Sorry, the previous paragraph. In the ileostomy, stool is still liquid. Yeah, it's ileostomy. It's the last part of the small intestine entering the ascending colon. Okay. Now, clients need support and practical help with learning about self-care for an ostomy, eliminating gas-producing foods, odor-causing foods, and foods that may cause an obstruction will help to facilitate maintenance. So you're cleaning a ostomy that is called ostomy care. You're going to learn that with me on semester number 4. So it's very embarrassing for a patient to have this ostomy, and after eating foods that are producing gas, okay, or excessive odor, is very uncomfortable, especially if they are sharing a room with 4 patients, right? Or even they have family members coming to visit them. Even when the ostomy is closed and the back is there and it's closed, the odor is very bad. Okay, so you need to think about that. The goal is to advance to a customized diet that is acceptable to the client and accommodates individual food preferences as soon as tolerated. And here you have in the graphic, you can see the stoma here. And the first one is the ileostomy, is the last part of the small intestine. Then you have another stoma, colostomy, because it's in the colon, in the descending colon. Okay, so on the right side of your screen, you have, on the right side, you have the ascending colon, the transversal, and the descending colon. Rectal surgery. For a brief period after rectal surgery or hemorrhoidectomy, clear fluid or fiber-restricted diets help to reduce painful elimination and to follow for healing. Imagine a patient is having a hemorrhoidectomy, a lot of hemorrhoids, right? And they did the surgery, they removed the hemorrhoids, and now the patient is eating a lot of salads and raw fruits. High fiber content, so the need to poop is going to be incredibly high. So you need to avoid that because they need to rest. If they poop very often, they are going to have a lot of pain. Okay, special nutrition needs for patients with burns. The treatment for severe burns presents a tremendous nutritious challenge. The location and severity of the burn will greatly affect the prognosis and plan of care. And it all depends on the type of burn. Okay, so I am introducing you what I believe is an excellent source for you to study for NCLEX. Okay, most of my students are following this guy.
Our next topic is burns. Burns are injuries caused by direct tissue damage from exposure to either the sun, chemicals, thermal, like boiling liquids, and even electricity. Now, as you know, the skin is made of 3 layers: the epidermis, the dermis, and the subcutaneous tissue, that fatty, bubbly looking tissue. Now, after the layers of skin, we find fascia, muscle, and then bone. So in first degree or superficial burns, we have damage to the epidermis, the top layer. So we see dry with blanchable redness, meaning that when you press on the wound, the redness goes away. Now, second degree burns, called partial thickness burns, we have both the epidermis and dermis that are damaged. So the key sign to know is painful blisters, huge NCLEX tip. So write down these keywords here. Red, moist, and shiny fluid-filled vesicles, or basically blisters that often leak fluid. So just think 2 layers of skin for 2-degree burns, or second-degree burns. Now, third-degree burns are full-thickness burns. We have 3 layers of skin destruction: the epidermis, the dermis, and possible subcutaneous tissue, described as key terms: dry, waxy white, leathery, or even charred black color that is non-blanchable skin. Big key terms for exams. Now, fourth degree, also a full thickness burn. These are the worst burns by far, as they go through all the layers of skin down to the muscles and even the bones. A unique sign is the lack of pain, since the destruction of nerve endings from all the burn charred areas. Even though they may look similar to third degree burns, these are far worse since they're far deeper. Now, for minor burns, like the first and second degree burns, these do not typically need hospitalization and can be treated outpatient with wound care and dressing changes. Whereas major burns like third degree and fourth degree, these are deadly medical emergencies, requiring intensive care, which we'll cover in a moment. So first, care for minor burns. Say a client is cooking and then burns themselves, or say they spill a boiling pot of water on an extremity. So we always teach the 3 C's for pre-hospital care: cool water, cover the area, and clothing removal. So for pre-hospital care, C for cool water, key terms, is briefly soak the area. And no ice, no creams, and definitely no antibiotic ointment to open skin. The key term there is open skin. So this can lead to additional damage, and the creams, lotions, and antibiotics may interfere with the assessment from the healthcare provider. Now, the second C is cover the area with key term, clean, dry cloth. So write that down. This is done to prevent infection and more damage in the pre-hospital setting. And the last C is clothing and jewelry removal near the burn, if not adhering to the burned skin. Only the HCP should remove anything adhering to the burned skin. So please be sure to write that down. Now, Saunders mentions, the nurse instructs firefighters that in the event of a tar burn, which is the immediate action? Cooling the injury with water. Yes, that was our first C there. And the second question, for a chemical burn injury, the nurse instructs the employees that which is the first consideration in immediate care: removing all clothing, gloves, and shoes, and any undergarments. Just strip down like you're going skinny dipping. Now for Kaplan, thanks for watching.
So as you see, we were missing the Kaplan part, okay? Also, I'm very worried because this textbook is not talking. Probably you're gonna learn that on MedSearch 2 or 3, or maybe the last semester with Professor Taylor, about the rule of 9 of the burns. Okay, that is coming in NCLEX. So I know probably you are not going to pay attention to this video and this resource now, since you are not heading to graduation, but these videos are going to be available in my channel for you to come back whenever you feel like. When you're preparing for your NCLEX, this video, especially this channel that I show you, he has amazing resources for you to study, and also hints and tricks like the triple C, right? Also, if you go to the rule of 9, also you're going to have good hints for studies and acronyms. So that's why I'm providing this video. I know these make my own lectures longer, but it's very worth it that you have all these resources available. Okay, stages of nutritional care Energy expenditure in burn patients can be extremely high, and it will fluctuate depending on the stage of healing and the extent of the body surface area involved. So here is when the rule of 9 come into place. How much area was involved and what type of burn? Is it a first degree, second degree, third degree? Okay, so now the nutritionist is going to decide, I'm going to give more proteins, more fat, depending on the degree of burn. Okay, here you have a nice graphic about the layers, the epidermis, the dermis, the fat, the muscle, the bone, and burn shock of the EBB phase. The EBB is the first phase where early shock occurs and hypometabolism. During this time, patients experience a decrease in metabolism and tissue perfusion. Burn shock is a condition resulting from the loss of large amounts of fluid that occurs during the first hours until approximately the second day after a burn. Try to start grasping this knowledge little by little, because whenever you get to the 5th semester, you're going to be bombarded with the specific questions. And if you miss it because you didn't study this now little by little, you are not going to pass the 5th semester. It's going to be very painful that you cannot graduate because you don't have enough knowledge. I'm telling you up front, it's happening. Okay, the destruction of protective skin leads to immediate losses of heat, water, electrolytes, and protein. Blood volume and pressure drop, and urine output decreases to replace the fluid lost from the wound. So the urine goes back into the system somehow, right? The kidneys are not going to release urine, but they are going to send the fluid back to the system to balance the fluids that the burns are the fluids that are lost because of the burn, right? Potassium increases in the circulation as the body withdraws potassium from the cells. This is a complete shift of electrolytes. To prevent shock, physicians replenish patients with large amount of IV fluid and electrolyte therapy, giving us a lactate drinking solution. So that's good to know. Intravenous electrolyte is given in the initial state during severe burn, especially lactated ringers. That's good to know. After the patient receives fluid resuscitation, the dietitian establishes nutrition needs. So it's going to assess food via orally or enteral. Acute or flow phase. We are moving from the first stage, which is called the EBB, right? And now we are moving into the acute phase. In that phase, a period of increased cardiac output and metabolism known as the flow phase. During this time, the body has added nutrient and energy demands because of metabolic stress, tissue growth, and repair. Okay, so at the first stage, we are bombarding the patient with lactate ringers full of nutrients. In the acute flow space, right now the patient is kind of recovery. If feedings do not meet nutrient demands, patient may lose muscle mass and experience a decreased ability to heal wounds in this stage. Okay, this acute phase of hypermetabolism may last from weeks to months. So the first stage, we are bombarding the patient with lactate ringers in order to establish balance and also to treat the hypometabolic stage. On the second stage, we are having a patient that feels better, but if the nutrients are not there, the patient is going to lose mass, right? And this is going to be a hypermetabolism stage. Okay, during this phase, the patient blood flow and urine output begin to return to normal. That's the difference with the first one. Constant attention to fluid intake and output with evaluation for signs of dehydration or overhydration is essential. So if the patient is getting 2000 mLs of fluids, now we are expecting more than 2000 or around that in urine output. Okay, so you need to monitor that, because if not, also we're going to evaluate for kidney function, right? Medical nutrition therapy for burn patients. Most patients with burns and of less than 20% of the TBSA. Dr. Matalana, what is TBSA? Your total body surface area. Total body surface area. That's why the rule of 9 is so important. They are dividing the body in different areas, and you need to know when they give you report, they are going to tell you, for example, the patient is having 3% of the body compromise of the arm. So that is the rule of 9. Okay, you need to know what is the equivalent when both legs are having the burn, with both arms, only the trunk. Okay, so most patients with burns of less than 20% of the total body surface area can consume an oral meal plan that is adequate in nutrient needs, unless the burn site hinders eating. Successful nutrition therapy during this critical feeding period is based on vigorous protein and energy intake as follows. So you need adequate energy. The dietitian is going to calculate the energy need. Also, we have to consider adequate energy intake spares protein for tissue rebuilding and meets the increased metabolic demands of the whole body. We need to consider high protein, crucial to promote early wound healing and the support immune function. We need to consider high micronutrients needs, again, because you always get confused between macronutrients and micro. Macro is your protein, carbs, and fats, and your micro is going to be your minerals and vitamins, right? So it's important your vitamin C for wound healing. It's important your vitamin A, which is part of your fat soluble component. Zinc is important for the immune function. All your vitamins B for nerves, right? Because in a burn there is a tissue compromise, but also a lot of nerves that are suffering the consequences of this event, right? And special attention to electrolyte levels, your potassium, your sodium, your magnesium, your calcium, chloride, la 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 la. Okay, so in table 22C, 6, you're going to see the estimated energy needs for burn patients, right? Based on the age, girls 3 to 10, all the way to boys 10 to 18, and the formula they are going to use, right? There are equations. One is the Toronto, the Schofield, la la la. Dietary management. Caregivers may provide nutrient-dense beverage with other protein or amino acids. Now we understand the value and the importance of amino acids, or commercial formulas such as Ensure or Boost to supplement the patient's diet. Remember, we said commercial formulas are having this sterile component, right? Versus the formulas that we prepare at home, that are whole food puree that we prepare at home, that can put the patient at risk for infection. We reviewed that in the previous videos related to these chapters. Patient usually tolerate solid foods by the second week. However, hypermetabolic states, pain, and poor appetite make oral feedings difficulty for individuals with major burns. So follow-up reconstruction is important. Patients need the physical rebuilding of body resources that surgery requires, as well as personal support to rebuild their will and spirit, because disfigurement and disability are possible. And with this, we are finishing one of the most important chapters that are going to help you to perform adequately in the hospital environment, okay? Because we have covered a lot. All the nutritional for different type of patients that are having gastrointestinal surgery, patients that are having burns, right? Patients with different traumas, okay? And also we've covered nutritional for patients with different type of incidents, gunshot, burns, surgeries, if the patient is having problem in the neck, too many things. If the patient is comatose, if the patient is not able to use the mouth, the throat, the neck. So this chapter is crucial for you to handle your patients in the hospital. Also, I would say another important chapter is the cardiovascular. Okay, now we're finished this chapter. When we come back next week, something extremely important is everything related to immune system and the cancer patients. You cannot miss that. Okay, see you in class. Thank you for your attention.